And welcome back to Hematology. Today we are going to talk about our APTT differential worksheet and primary hemostasis case studies set number 2. Please do your best to work on these by yourself prior to coming and looking at the explanation and review. These are going to be very helpful for you as you prepare for your board exams or your in-class exams. So please don't shortchange yourself by just coming straight here to get the answers. All right, so we have already talked about mixing studies just a bit, and this is a very kind of an antiquated way of doing a mixing study. In this situation, we have adsorbed plasma, and it contains very specific factors, which I have listed for you at the top of your page, factors 1, 5, 8, 11, 12, and 13. And then we have aged serum. And aged serum contains factors 7, 9, 10, 11, and 12. So there are a couple of duplicates. So they both have 9, they both have 12. But for the most part, they do have some variation. Now, again, I just as a reminder put what are pro-time measures, which factors are pro-time measures here at the top. And I also put a little reminder of which factors the PTT measures. And then if you see FBG, that just stands for fibrinogen, so we're doing a fibrinogen assay. So that the way you kind of work through these, let's talk about kind of a strategy. So we're going to be going through and looking to see, first of all, look at each result to determine if the factor deficiency is in the intrinsic, extrinsic, or common pathway. How do we do that? Well, of course, we're going to look at our PT and our PTT first and see if there's any prolongation in the PT or the PTT. Next, we're going to look at the one-to-one mixing studies for both the adsorbed plasma and the aged serum. Both of them are the same. There is no change. We're going to look at the original PTT, and it's just the same as the PTT mixing study with the AP or the PTT mix study with the adsorbed or the aged serum, excuse me. So honestly, I don't see any abnormal values. Fibrinogen looks fine. There was no correction, but of course it wasn't prolonged to begin with. So I'm going to give you the first one for free. It is, I don't think that there are any factor deficiencies in number 1. Now let's look at the second problem. Pro-time is 12.1. Ask yourself, is that normal or is that prolonged? In our case here, that is normal. Our PTT is 46 seconds. What do you think? Yes, that is prolonged. Fibrinogen. And then we have a couple of mixed studies, one with the adsorbed plasma and then another one with the aged serum. And there is quite a bit of a difference here, right? Quite a bit of a difference. Normally we would run a PTT with just our plasma or our serum so that we'd have a comparison. This is kind of an antiquated way of doing it, but you get the idea. The PTT with the aged serum is the same as the patient PTT before the mixed study. There was no correction. And then the PTT with the adsorbed plasma does have a correction. You can see that it has come into a normal range. So even though we don't have the PT from the PTT from the adsorbed plasma or the aged serum, we can tell that it is a correction because it's brought it into a normal range. So I will leave you to it. I like to think of these as kind of like super mental Sudoku. If you need to, you can tally off different kind of put a little tally mark through each one of them as you're figuring them out. Whichever way you want to do it. I just really want you to try to complete these on your own prior to looking at your answers, but I will leave you to it, and we will go over on the next page, we'll go over the answer to this. Good luck. All right, so one of the ways that I like to solve my cases, I like to write out which pathways are covered by each factor, which factors are covered by which pathway. Now, we know that the PT measures the extrinsic pathway. So the extrinsic pathway for the most part is going to be factor 7, and then the other factors that are in the common pathway, 1, 2, 5, and 10. And then the PTT is going to measure 12, 11, 9, 8, 10, 5, 2, and 1. So again, those last four are associated with the common pathway. And we also have precalcrin and homework, or, you know. So anyway, I write those out for my own benefit when I'm doing these type of worksheets. And I found that when I was a student, it was very helpful to kind of have that visual. So if you need to do that, go ahead. These are the findings. I have put a little N next to the PT or the PTT or the fibrinogen if they were normal, and if they were prolonged, I put a little P by them, and then I marked as to whether or not there was a correction or no correction, and the result that I got for which was the factor deficiency. Okay, so let's look at this. We did the first one together already, and as suspected, there was no factor deficiency. The second one, there was a correction with the PTT mix with the adsorbed plasma, but there was no correction. So really what we need to do is we need to go up to the adsorbed plasma and see which factors that we could have potentially put in that are not present in the H serum. Because obviously something we've put into that mixing study has replaced the deficient factor that our patient was in need of. So let's take a look here. Well, factor 13 we know we don't typically measure it with a PT or a PTT, so that wouldn't be it. They both have factor 12. Let me get my little pointer here. So they both have factor 12. They both have factor 9. Let's see here. 11, 7, 8. Okay. So 7 is going to be associated with the intrinsic pathway, or the extrinsic pathway, excuse me. So that would have affected our PT, but it's our PTT that is prolonged, so it's not factor 7. And if it was factors 1, 2, 5, or 10, we would have prolongation in the PT and the PTT because those are both in the common pathway. So we know it's not factor 1, 5, 10, 7, 2 isn't in there, but it's not factor 2 because if it were factor 2, we would also see a prolongation in the PT because it's in the common pathway. So we know it's not the common pathway, so scratch those. None of those will be it. We know it's not factor 13. We know it's not factor 12 because that's in both. We know it's not factor 11 because that's in both. No, not 10, not 5, not 1, not 7. So the only thing that we added in that was in adsorbed plasma but not in H serum was factor 8. So that would lead us to believe that the factor deficiency that the patient had was factor 8. Okay, go ahead and try to work your way through these. I have posted the answers, but just go through them exactly the same way I just showed you. Number 5 is a bit tricky. Just use your common sense and see where you get. All right, here are a few more. Do your best. same thing. And I've posted that kind of that little key about which factors are in each of the mixing study reagents or plasmas or serums or whatever you want to call them. All right, sometimes when we're working through these mixing studies, it's hard to know whether it's one or the other because, for example, in number 6, we have a prolonged PTT and we have a correction in both the adsorbed plasma and the aged serum. The problem is the aged serum and the adsorbed plasma have both factors 11 and 12. So it could be either 11 or 12. And that's really as far as we can get until we do a factor assay. So it would be acceptable to say, okay, factor 11 or factor 12 could possibly be the deficiency. But the good thing is it kind of helps us narrow it down. We don't want to do every single factor. That's going to be expensive. It's going to waste our reagents and our time. If we can narrow it down to 1 or 2 factors we know could potentially be deficient, we could just go ahead and run those factor assays if, based on what the physician has decided and move from there. All right, our coag case study number 2. This is going to be associated with our primary hemostasis, and this is just with explanation and review. I, again, want you to work on these on your own and try your best to complete them. We can talk about them in class, or if you have any questions, you can text me, email me, what have you. Before we get started with the case study, I just wanted to post the platelet disorder study chart. It's going to have platelet aggregation patterns, bleeding times, counts, all of the distinguishing factors and test results that you would get in a platelet disorder, the name of the disorder, etc. So really study this. Again, this is posted in your coagulation unit as part of your review. This is a great study tool, especially when we're talking about platelet aggregation patterns and platelet disorders. All right, case study 1-2. A newborn baby boy has had bleeding with circumcision. There is no family history of bleeding, and the physical examination is normal except for scattered petechial hemorrhages over the extremities. Laboratory results indicate normal values for the PT, PTT, and platelet count. Peripheral blood smear reveals normal morphological characteristics for the red blood cells, white blood cells, and platelets. Okay, how would the bleeding disorder be categorized? What tests should be performed? And what is the molecular basis for the following disorders? So Glanzmann's thrombocythemia, Bernard-Soulier syndrome, and storage pool disease. So work on that, think about it, and then when you come back, we'll talk about it. Here we are again, case study 2-1. Now that newborn baby has had bleeding with circumcision and there's no family history. The physical examination is normal, except for the scattered petechial hemorrhages over the extremities, and all of the laboratory results are normal. The values are normal for the PT, the PTT, and the platelet count. And our peripheral blood smear indicating normal morphological characteristics for red blood cells, white blood cells, and platelets. So nothing out of the ordinary, aside from those petechial hemorrhages and some of that bleeding after circumcision. When we ask about classification for disorders, and specifically bleeding disorders, because a lot of times they have to do with either factors or platelets, we could categorize them in one of 2 ways. One, is this a quantitative disorder? Are we lacking something that we need? So are we lacking a factor? No, we're not, because all of our PT and PTT is normal. Are we lacking platelets? No, we're not. Now, theoretically, you could say that factor 13 is not measured by the PT or the PTT. And in that situation, you'd be right. But my bet is this is more probably a platelet dysfunction or a qualitative disorder rather than a quantitative factor 13 deficiency. The other reason why I say that is because those petechial hemorrhages are kind of an indicator of that as well. But we won't know for sure until we do further testing. What do you guys think? Do you think we should do a platelet screen or a platelet function assay rather? Or should we just go straight to that von Willebrand's? Now, the thing we have to remember is sometimes in the laboratory, we have to really prioritize the testing that we perform. And in this case, this is a brand new baby boy, a little tiny human who doesn't have a lot of blood volume. So we really have to prioritize. If the physician were suspecting a qualitative platelet dysfunction disorder, I'm betting he would probably and most likely perform the von Willebrand screen first. And I'll tell you why. It requires much less volume than a platelet function assay and much, much less volume than a platelet aggregation. And it includes a factor 8 factor assay, a von Willebrand factor antigen, and activity. So you're really getting quite a bit of information. Factor 8, of course, is one of the most common hemophilias. It is the most common hemophilia. It's hemophilia A. Von Willebrand factor antigen, we would be looking for, are we lacking von Willebrand factor antigen, or is it just not functional? It's not working. Now, if those all came back normal, I could see the doctor maybe performing a PFA and then going from there. If that were abnormal, maybe a platelet aggregation study would be performed, but only if enough blood could be obtained. And because of the baby's small size, chances are if he does not have any hemorrhagic tendencies and he's just having a little bit of bleeding, maybe some oozing, they may wait until he's a little older to carry out those tests when he has a little bit more blood volume. What is the molecular basis for the following disorders? So Glanzmann thrombasthenia. All right, well, this is pretty simple. This one is a qualitative disorder, and it is an abnormality of that platelet fibrinogen receptor. So that glycoprotein 2B and 3A, and that causes impaired aggregation. The Bernard-Soulier syndrome is an abnormality of platelet von Willebrand receptor. So remember at the subendothelial interface, we've got that von Willebrand's, and we've got that little glycoprotein 1B coming down to hold on to the von Willebrand so that it has a stronger adhesive quality. Yeah, in this case, that's either dysfunctional, not the right size or the right shape. There's some type of abnormality in the protein. So it leads to a defective platelet adhesion. And then we have storage pool disease. This is a deficiency of ADP and ATP within those dense granules. And that leads to a defective secondary wave of aggregation. So release is not going to be appropriate because this is a problem with the number of granules and dense granules. So ADP, which is one of our agonists, would simply be deficient. And so when that secretion event occurs or that release event occurs of those granules, things wouldn't work the way they're supposed to because there aren't enough of those. All right. Case study 2-2, a 33-year-old woman is admitted to the hospital for hysterectomy for uncontrolled menorrhagia, requiring a 5-unit RBC transfusion. She has had several transfusions for blood loss from menorrhagia in the past and reports easy bruising, epistaxis since childhood, so she's getting nosebleeds. She has one cousin who is a bleeder, and she takes aspirin for headaches, but is taking no other medication. Results of the physical examination are normal. Initial laboratory tests indicate normal values for the PT, PTT, thrombin time, and the platelet count. Okay, well, how does aspirin ingestion influence platelet function? Okay, she does take aspirin for headaches apparently, but is not taking any other medication. How will aspirin interfere with platelet function testing? Well, what do you guys think? All right, continue on with this case study. I will come back and we'll go over it on the next slide. Try your best to finish before you get to the next slide. Here we are back at case study 2-2. A 33-year-old woman is admitted to the hospital for hysterectomy for uncontrolled menorrhagia, requiring a 5-unit red blood cell transfusion. She has had several transfusions for blood loss from menorrhagia in the past and reports that easy bruising and epistaxis since childhood. She has one cousin who is a quote-unquote bleeder. She takes aspirin for headaches but is taking no other medication. Results of the physical examination are normal. Initial laboratory tests indicate normal values for PT, PTT, thrombin time, and platelet count. So could it be the aspirin that she's taking is causing her to have some platelet dysfunction? Well, maybe. Let's look at this. How does aspirin ingestion influence platelet function? Well, if you think back to our primary hemostasis or our platelet disorder lecture, we know that aspirin irreversibly inactivates platelet cyclooxygenase, which prevents the formation and release of that thromboxane A2. Now remember, there are a couple of things that regulate platelets, and one of them is thromboxane A2, and without that, they cannot be activated, and they just they don't function anymore. So, and then that lasts for the entire lifetime, the lifespan of the platelets that were exposed to that aspirin. If we were to do platelet testing or platelet function testing on a patient who was taking aspirin, these are some of the results that we would find. We would find a prolonged closure time with ADP and epinephrine on the PFA 100. And with regard to our platelet aggregation study, the platelet aggregation would be decreased with ADP and collagen. It would be completely absent with arachidonic acid and very normal with ristocetin. What effect does aspirin have on a normal population's bleeding time? Well, honestly, if it was a problem, they wouldn't allow people to buy it over the counter. Really, the only time that aspirin is typically a problem is if a patient takes too much of it or they have an underlying hemostatic problem. So if you think about the lifespan of a platelet is only about 8 to 12 days, we have constant turnover of platelets. And so the only platelets that are dysfunctional are the ones who have been exposed to aspirin at some point in their life. Again, it's irreversible, but there are constantly new platelets coming in. As long as you're not taking aspirin every single day in high doses, typically for the normal population, it's not a significant problem. We could perform some tests on this patient. We really don't have any way of knowing what's going on exactly, but we could do a von Willebrand panel. We know that von Willebrand disease is associated with menorrhagia, especially in and it's more prominent or prevalent in women. I mean, of course, men don't menstruate, but I'm saying von Willebrand's is more prominent in women or more common. So we could do that von Willebrand panel with the factor VIII assay, the von Willebrand antigen, and the von Willebrand factor activity, just to see what we're looking at there. Okay, so there are a couple of characteristics and a couple of other platelet disorders that could be mistaken for von Willebrand's disease, and one of them is called Bernard-Soulier. Now, Bernard-Soulier has exactly the same aggregation pattern in terms of platelet agonists as von Willebrand's disease. if you were to have von Willebrand's disease or Bernard-Soulier disease, your platelet aggregation would look like this. It would be normal in response to ADP, collagen, and arachidonic acid, but it would be decreased with ristocetin. And so, since a lot of the signs and symptoms of Bernard-Soulier disease and von Willebrand's are so similar, platelet function tests or platelet aggregation patterns are the same. It's really difficult to determine one from the other unless we do further testing. Now, there is one little thing. Bernard-Soulier has a couple of differences with regard to the characteristic blood smear findings. What we typically find in Bernard-Soulier disease that we do not find in von Willebrand's is we find giant platelets with Bernard-Soulier and variable thrombocytopenia. Now, it may be more significant in some patients than others, but thrombocytopenia is a common finding, meaning they have a low platelet count. This patient clearly does not have a low platelet count, and she does take aspirin, so it makes you wonder. We've got to figure out what's going on with her. In what disease is clot retraction abnormal? And again, that's going to be that Glanzmann thrombasthenia. Of course, clot retraction is going to be abnormal because we can't, platelet aggregation can't occur. Case study 2-3. All right, so a 22-year-old woman seeks medical attention for a possible bleeding disorder. She has had easy bruising and intermittent nosebleeds since childhood and recently noticed heavy menses. She also bled excessively after a tooth extraction. She has a sister with similar symptoms and a brother with nosebleeds and bleeding after a tonsillectomy. Uh-oh. Her mother had menorrhagia and excessive bleeding after surgical procedures. The patient had otherwise been healthy, and results of her physical examination were all normal. Now, in this case, we don't really get too much information with regard to her lab results, but see if you can figure it out. Go back, look at your platelet aggregation studies, look at your autosomal dominant bleeding disorders. Take a look and see if you can figure out what we might be looking at. And I will see you on the next slide. Back again, case study 2-3. A 22-year-old female seeks medical attention for a possible bleeding disorder. She has had easy bruising and intermittent nosebleeds since childhood and recently noticed heavy menses. She has also bled excessively after a tooth extraction. She has a sister with similar symptoms and a brother with nosebleeds and bleeding after tonsillectomy. Her mother had menorrhagia and excessive bleeding after surgical procedures, and the patient had been otherwise healthy, and results of her physical exam are normal. Okay, so in this case, we are not given too much information about her laboratory results, but let's see what they want. What is the most likely autosomal dominant bleeding disorder that is suggested by this patient's history? Well, looking at her family history, she certainly has some type of inherited disorder. She has 2 siblings and a parent. She's a female, and all of those things that symptoms and signs and symptoms that we're looking at could be very indicative of von Willebrand's disease. That would be my suspicion. What is the most common sex-linked recessive bleeding disorder? That would be factor VIII deficiency, which is hemophilia A. All right, so the third question says, list the similarities and differences between these two disorders. So we know that von Willebrand and factor VIII are closely associated. In fact, von Willebrand and factor VIII are kind of like frenemies. They're kind of codependent. And in fact, factor VIII needs von Willebrand factor to help stabilize him or her. Like I said earlier, some of these factors get a little wily. So let's look at our PT. If the patient had von Willebrand's disease, the PT would be normal, and the patient with hemophilia A would also be normal because, again, hemophilia A is a part of, or factor VIII deficiency is a part of the intrinsic pathway. So PT would not be prolonged at all. The PTT for a patient with von Willebrand might be normal or it might be increased. A patient with factor VIII deficiency, also known as hemophilia A, would be increased. So we'd have prolongation there. Platelet count would be normal in both. Platelet function assay 100 would be prolonged with epinephrine and normal with hemophilia A. Our platelet aggregation pattern with von Willebrand's would be normal with everything except for ristocetin, and we would see it decreased or maybe absent with ristocetin. And platelet aggregation pattern would be normal for hemophilia A. Von Willebrand factor antigen would be decreased, but von Willebrand factor antigen would be normal if the patient had hemophilia. Von Willebrand factor activity would be decreased with von Willebrand's disease and normal in hemophilia A. And then our factor VIII assay would be decreased or normal in von Willebrand disease, but it would be decreased in hemophilia A, sorry. We made it to case study 2-4. Can you believe it? Primary hemostasis is fun, right? All right. A 74-year-old man was hospitalized for unstable angina. He subsequently underwent a coronary artery bypass graft and did well in the immediate postoperative period. At admission, his CBC, PT, and PTT values were all within normal limits. But 5 days later, he developed left foot pain. An angiogram revealed arterial thrombosis. The platelet count at the time was 77. The platelet was then heparinized and underwent surgical embolectomy, so they removed the blood clot surgically. Later that day, the right foot was noted to be cold and pulseless. At this time, the platelet count was 17, the PT was 15, and the PTT was 52 seconds. Ooh, that doesn't sound too great. What is the likeliest diagnosis and how can it be confirmed? Okay, so go through your notes, see if you can figure this one out. You might find this one to be a little bit tricky. But what I can tell you is that if we haven't talked about it yet, you can always come back and work on this one later. If you really feel like you can't get it and you don't want to look at the answer yet, that's okay. I'm not sure if we have gotten to this particular issue. We haven't done our lecture on coagulopathies yet. So if you want, just hold off on this one. We will get to it. We'll come back to it. But I will go ahead and post the answer so that you can look at it and digest it at your on your own time. You made it back. We are working on case study 2-4, and we are talking about a 74-year-old man who was hospitalized for unstable angina. He subsequently underwent a coronary artery bypass graft and did well in the immediate postoperative period. Upon admission, his CBC, PT, and PTT values were all within normal limits, and yet 5 days later, he developed left foot pain. An angiogram revealed arterial thrombosis. The surgical count at the time was 77, and the patient was heparinized and underwent a surgical embolectomy. Later that day, the right foot was noted to be cold and pulseless. Uh-oh. And at this time, the platelet count was 17. The PT was 15, and the PTT was 52. I think I know what's going on here, you guys. This is no good. All right, so we haven't really talked extensively about anticoagulant therapy with regard to heparin. We talk really more about that as we get into our coagulopathies and even our fibrinolysis. But I will say that heparin is a commonly used anticoagulant therapy, especially for post-surgical, because it helps mitigate the risk of deep vein thrombosis and emboli. However, some patients actually form an IgG antibody against this heparin PF4 complex. So that platelet factor 4 binds to the heparin. Heparin interacts with antithrombin. And honestly, when those IgG antibodies are formed, that IgG antibody they start to just coat those platelet complexes, and the platelets are then destroyed, which leads to a thrombocytopenia, which has been heparin induced. So heparin induced thrombocytopenia would be my guess. Whenever you see a patient who's been heparinized and all of a sudden their platelets just fall through the floor, within a few days of being on heparin, my first thought is, oh no, I hope this is not an HIT. Now, it's really easy to test for. Heparin antibody ELISA assays are really easy to perform. They're a little bit time consuming, but they're kind of fun as well. It is something that we perform here at our facility. Maybe when you're on the bench, you'll be able to see a tech performing that for you, or in front of you, you'll be able to see that and observe that. It's not something we have students perform, but you're more than welcome to observe, and we can explain the process. The appropriate treatment for the diagnosis is obviously to remove the heparin from the patient's course of treatment. We might swap it out for an alternative anticoagulant therapy, such as a direct thrombin inhibitor, which is another class of anticoagulants. But unless the physician really insists, that patient really probably shouldn't be put on heparin anymore. Now, in the event that for some reason they are put on heparin and it's, maybe they have to be put on heparin for some reason that is outside of my pay grade to understand, but they could suppress the immune system to prevent an over proliferation of that IgG. However, most doctors aren't going to go to that trouble unless there's good reason, and so they would just prescribe them a different class of anticoagulants, like again that direct thrombin inhibitor. Case study 2-5. A 25-year-old woman, 19 weeks pregnant, presented to her physician with a headache and left flank pain. Her platelet count was 7. Oh no, this is bad. A urinalysis showed proteinuria and pyuria. Her UTI was treated and she was transferred to another hospital for diagnosis and management of severe thrombocytopenia. The physical examination revealed scattered petechiae and bruises all over the lower extremities and an abnormal mental status. The peripheral blood smear showed a left shift in the white blood cells and occasional red blood cell fragments. Additional results included LDH of 30,000 and a D-dimer of 1.0. Results of her liver and renal function studies were normal. A diagnosis of thrombotic thrombocytopenic purpura, also known as TTP, was made, and the patient was treated with corticosteroids and daily plasmapheresis with fresh frozen plasma. Her platelet count normalized after 4 days of plasmapheresis. 2 years later, the patient developed fatigue, headache, and easy bruising. She was found to be anemic and thrombocytopenic with a platelet count of 20. Mental status and neurologic examination results were normal, but the blood smear revealed red cell fragments. TTP was again diagnosed, and she responded again to plasmapheresis with fresh frozen plasma and corticosteroids. So, TTP, oof, I've seen it a few times, and I always just dread it when I see it. Some people do fine, and other people don't do so well. All right, try to answer questions 1 and 2, and we'll come back and take a look together. Good luck. Welcome back to Case Study 2-5. A 25-year-old woman, 19 weeks pregnant, presented to her physician with a headache and left leg pain. Her platelet count was 7. A urinalysis showed proteinuria and pyuria. Her UTI was treated, and she was transferred to another hospital for diagnosis and management of severe thrombocytopenia. The physical examination revealed scattered petechiae and bruises over the lower extremities and an abnormal mental status. The peripheral blood smear showed a left shift in the white blood cells and occasional red blood cell fragments. Additional results included LDH of 30,000 and a D-dimer of 1.0. Results of liver and renal function studies were normal. A diagnosis of thrombotic thrombocytopenic purpura was made, and the patient was treated with corticosteroids and daily plasmapheresis with fresh frozen plasma. Her platelet count normalized after 4 days of plasmapheresis, and 2 years later the patient developed fatigue, headache, and easy bruising. She was found to be anemic and thrombocytopenic with a platelet count of just 20. Mental status and neurologic examination results were normal, but the blood smear revealed red blood cell fragmentation. TTP was diagnosed, and she responded again to plasmapheresis with fresh frozen plasma and corticosteroids. So let's think about TTP. Well, TTP has an interesting kind of biochemical basis. What we have in TTP are endothelial cells that secrete these large von Willebrand factor multimers, and normally those would be cleaved, but they can't be cleaved by ADAMS13. Sorry, that's ADAMTS13 enzyme. And this leads to an excess platelet adhesion and thrombosis, resulting in thrombocytopenia. So this is becomes kind of a consumptive disorder, because now we have an overactivation due to those von Willebrand multimers that are normally cleaved by ADAMTS13 enzyme. It's just, they're going to have clotting, and then they're going to have thrombosis, and then they're going to have thrombocytopenia because all their platelets are getting used up in those clots. How should this patient's TTP be treated? Well, there's one very important thing that physicians and nurses and healthcare providers should know. We do not transfuse platelets to patients with TTP. Do not. We will do plasmapheresis, but if we transfuse them with platelets, it's just going to lead to more clotting. It's going to be like throwing gasoline on a little tiny fire, and next thing you know, it's going to be consuming that gasoline and just raging out of control. And that's kind of how consumptive disorders can behave. So we don't want to add fuel to the fire by putting more platelets in. We want the body to be able to recover, perform plasmapheresis, and hope that that treatment works for her. All right, that is the end of our primary hemostasis case studies. Thank you for joining me. Continue to study hard. You're doing great. If you have any questions, again, feel free to contact me, email me, call me, text me, stay after class, whatever your little heart desires. I am here for you. And I will talk to you next time. Have a great day.